This patient's gums are swollen in the setting of an infiltration by acute myeloid leukemia. It's very unfortunate. Hi, my name is Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology, every single thing. In today's talk, I'll be discussing acute leukemia pathology. Make sure you have your book. You can scan this and find it very quickly if you don't have it already. All this information is contained within there. It's very important to have if you want to be on track. All right, so acute leukemia. Acute leukemia is the neoplastic proliferation of blast cells. In this image to the right, we can see histopathology of T lymphoblastic leukemia on a peripheral blood smear. You see all those blasts. Now, the abnormal blood cells in acute leukemia are immature blood cells called blasts. Acute leukemia is defined as the accumulation of greater than 20% blasts in the bone marrow. You're going to need to know that number, 20%. Now, how does acute leukemia typically present? Well, it typically presents as anemia, fatigue, thrombocytopenia, random bleeding, and neutropenia. The white blood cell count is often high when blasts enter the bloodstream. Blasts are large, immature cells that frequently have nuclei that look punched out, as you can see here in the right. See all those blasts, those immature basophilic cells with a high NC ratio? Based on the phenotype of the blast, acute leukemia is further separated into two major subdivisions, which include acute lymphoblastic leukemia or acute myelogenous leukemia. Acute lymphoblastic leukemia is a malignancy in the blood and bone marrow. To the right, we can see some blasts associated with acute lymphoblastic leukemia. Those aren't neutrophils. Those aren't regular lymphocytes. You see those three basophilic cells with the high NC ratio with somewhat of a abnormal nuclei? Those are blasts. Acute lymphoblastic leukemia is defined as neoplastic accumulation of lymphoblasts greater than 20% in the marrow. A DNA polymerase called terminal deoxynucleotide transferase, or TDT for short, positive nuclear staining identifies lymphoblasts. Myeloblasts and mature lymphocytes do not contain terminal deoxynucleotide transferase. Children are most frequently affected by acute lymphoblastic leukemia. So all the future pediatricians out there, make sure you have this high on your differential. Patients with Down syndrome are at increased risk for acute lymphoblastic leukemia. Do you remember the cytogenetics for Down syndrome? Is it monosomy X? Is it trisomy 21? Is it XXY? Right, you know Down syndrome's trisomy 21. Good job, great job. All right, acute lymphoblastic leukemia is linked to Down syndrome, which typically manifests after the age of 5. Based on specific surface markers, acute lymphoblastic leukemia is further subclassified into T cell lineage or the B cell lineage. B cell acute lymphoblastic leukemia is more common than T cell acute lymphoblastic leukemia. BALL is characterized by lymphoblasts, which will express TDT positivity, that also express some B cell markers, which include CD10, CD19, and CD20 in general. BALL displays a fantastic response to chemotherapy. BALL treatment requires prophylaxis to scrotum and CSF. Cytogenetic abnormalities are useful to gauge the prognosis of BALL. BALL with translocation 1222 is seen in children more than adults and has a good prognosis. Philadelphia chromosome positive BALL or PH positive BALL is seen in adults more than children and has a poor prognosis. TALL is distinguished by lymphoblasts that express TDT positivity that also express CD2, CD3, CD5, CD7, and CD8, those T cell markers, right? Acute lymphoblastic lymphoma is so named as a mediastinal thymic mass, and it typically manifests in teenagers because the malignant cells form a mass. Acute myeloid leukemia is a malignancy of the blood and bone marrow. Here we see this image to the right that's showing the swollen gums due to infiltration by what? Acute myeloid leukemia. Acute myeloid leukemia is a neoplastic accumulation of myeloblasts greater than 20%, as you know, 20% in the bone marrow. To the right here, we have a image showing acute myeloid leukemia. Regarding acute myeloid leukemia, myeloperoxidase positivity, also known as MPO positivity, myeloperoxidase positive cytoplasmic staining is typically a feature of myeloblasts. You'll see these crystal aggregates of myeloperoxidase positive cells, which may be seen as Auer rods. You have to know that. Auer rods. Now, what are Auer rods? Well, Auer rods are needle-shaped large crystals which are cytoplasmic inclusion bodies and are occasionally seen in myeloid blast cells during acute myeloid leukemia. Acute myeloid leukemia typically strikes elderly people between the ages of 50 and 60 years old. Acute myeloid leukemia is subclassified based on surface markers and cytogenetic abnormalities. AML can also develop from pre-existing dysplasia such as myelodysplastic syndromes, particularly in cases when alkylating drugs or radiation therapy were previously used. Now, the typical findings of acute myeloid leukemia include cytopenias, really low white blood cell, platelet, RBC counts, cytopenias, a hypercellular bone marrow, right? Because we know when we have a bone marrow biopsy, the cellularity should be 100 minus the patient's age, plus or minus 10 for the most part. But in cases of acute myeloid leukemia, the bone marrow biopsy will show diffuse spread of these blast-like cells in general, hypercellularity. There will also be abnormal myeloid cell maturation and increased proportion of blast cells, again, greater than 20%. Patients with acute myeloid leukemia are at risk of death due to infection or hemorrhage, right? And that makes sense because they're not producing the proper white blood cells to fight off and stave off infections, and they're not producing proper red blood cells or platelets to stop the hemorrhage. Now you have to know this. Acute promyelocytic leukemia is a subtype of acute myeloid leukemia that involves translocation of the retinoic acid receptor on chromosome 17 to chromosome 15. So you have a 15-17 translocation. Now, make sure that this image here to the right is burned into your cortex, because you see something on here that's very, very, very important. You're going to see it again in the future, probably short future. You see all those Auer rods? You have to know that. And now you do. And you know that they're important. When retinoic acid receptor is disrupted, maturation is prevented and promyelocytes, blasts, accumulate. Acute promyelocytic leukemia with the Auer rods is treated with vitamin A derivative all-trans retinoic acid. That's the treatment. And what it does is promotes the maturation of all those abnormal blasts with the Auer rods so that they differentiate, move from promyelocytes all the way down to neutrophils, and they come out in the system and properly stave off infections, right? That's what we want. The vitamin A derivative all-trans retinoic acid binds to the altered receptor and induces the blasts to mature into neutrophils. Acute myelocytic leukemia is a subtype of acute myeloid leukemia. Acute myelocytic leukemia is characterized by the growth of monoblasts and typically lacks MPO. These blasts characteristically infiltrate gums. And you made it through this very important lecture. Bravo to you. Man, you're doing such a great job. I'm proud of you. Keep up the good work. Make sure you're using your book. Make sure you're subscribed. Make sure you have access to the website because the updates take place there. Keep studying. Keep doing a great job. I'll see you on the next one. Bye-bye.